Welcome, everybody. This is the Thrombosis Network rounds, and as many of you know who've joined us before, we run this on Thursday afternoons, and typically we have one of our thrombosis fellows present on a topic. Sometimes we talk about unusual cases, and last year and certainly this year, we're going to try to also bring in speakers with expertise in thrombosis that we collaborate with very often. And to start things off for us this year is Dr. Thalia Field. I think many of you know Thalia from her years at VGH. I actually, not to date myself, but I met Thalia when Thalia was the neurology fellow who actually lovingly and amazingly took care of my mom. So we go back way many, many years. So we have Thalia today with us, and she's going to give us an update in cerebral venous thrombosis. And some of you may know, and for those who don't, Thalia is actually a world-leading authority now on cerebral venous thrombosis, and she's been very, very active in this area. Recently completed a randomized trial, and so I'm sure she's going to be able to share with us, the latest and greatest in management of this problem. So thank you very much, Thalia, for joining us today. I think everybody knows this is a recorded lecture. This will be posted on the Thrombosis Network website. The question and answer period will not be recorded, just so everybody could feel more comfortable about, talking about specific maybe patient cases, that sort of thing. And so again, just the formal presentation will be recorded. So if you have to, run out or skip a few minutes, you can always go back and watch the whole thing again. So thank you again, Thalia.
Okay, thanks so much, Aggie, for that kind introduction. I know so many of you, and it's lovely to see your names and faces, and I am so grateful for the expertise and the collaboration of the thrombosis community locally. You guys are wonderful. I really appreciate all the help and knowledge exchange we get through our shared patients. So thank you for all your support. It is my pleasure to speak to you about cerebral venous thrombosis. These are my disclosures. I really, I've given a version of this talk before. I get a little bit manic because I'm really passionate about this topic. So I've kind of had to hold myself back a little bit. So I'm just going to give you some of it. I think the highlights that are most important for the thrombosis community related to epidemiology, clinical presentation, acute treatment, primary anticoagulation, and prognosis, and just kind of weave in some of the uncertainties as we go along. So what's interesting about cerebral venous thrombosis, I think, there've been all these studies recently that talk about increasing incidence as compared to previous. And it's been interesting teasing out what the potential differences and reasons for that may be. So Lily Zhou, who is one of our newer stroke neurologists at VGH, and who previously did a fellowship at Stanford and CIHR-funded research as part of that with my group with BC Data, did a meta-analysis looking at the overall incidence in international groups about cerebral venous thrombosis, and somewhere between 10 to 12 per million per year. But we have that increasing incidence that's been reported over time, and you can see just kind of that increasing trajectory in the BC specific data alone that's happened. And what's kind of interesting is that this certainly mirrors the number of CT angiograms that we've been doing at VGH. You can see kind of started my residency in 2007. We almost weren't doing any for anything. And then just kind of for any indication, whether that's stroke or TIA workup or trauma or headache or whatever, certainly it's one of the most important biomarkers that we use in our diagnosis. So certainly I think a large component of that is greater ascertainment with increased use of vascular neuroimaging. But the other piece along with that is that, in some groups, such as older patients and in males, in some series selectively, the incidence seems to be increasing in those groups in particular. This is US data on this side, and And what they found that was interesting is that, again, alongside these kind of selective increases in men and older patients overall, a lot of these were associated with comorbid codes related to malignancy and trauma and inflammatory disease. So kind of a more particular risk profile for those patients. So it's also possible that there are more cases because, people that were otherwise, more frail and maybe not diagnosed, or maybe who would not have survived, are increasingly being diagnosed with cerebral venous thrombosis. The other thing that's just kind of interesting with the data that Lily looked at in BC, and we see these trends reflected in data elsewhere, is that we think of this as a disease that primarily happens in younger women, and while it's true that younger women still do make up the majority of the incidence of the disease, once you get past kind of menopausal age, you'll see that there's far more sex equity in terms of men versus women. This is an Italian series, and this is BC data here, and there's been an international genetic collaboration study, and basically that they found that cerebral venous thrombosis, the onset was earlier in women overall, but basically in the context of sex-specific risk factors. Another series from another big observational study, the International Study of Cerebral Venous Thrombosis, also found that, in women that didn't have sex-specific risk factors like being on the oral contraceptive or postpartum, their risk factor profile and outcomes were very similar to men with cerebral venous thrombosis. In general, cerebral venous thrombosis associated with oral contraceptives is associated with a better prognosis overall. So, I think that is kind of interesting, and I think it's kind of shifting our thinking about having a different index of suspicion in different populations overall. I think the other thing that remains to be seen is how much COVID being endemic will shift incidence rates of cerebral venous thrombosis. Most of the data is from the alpha wave, and I think we're still teasing out patterns, but what seems to be clear is that both in community-based and hospital-based cohorts, that the incidence of cerebral venous thrombosis associated with COVID is high, like 20 to 40 times as high, and also that in COVID kind of stroke-related series and general stroke cohorts that have COVID, CVT makes up about 5%, as opposed to kind of other observational stroke cohort studies that are hospital-based, where stroke is 1% or less, CVT is 1% or less of all stroke. And this is just kind of like for fun and for your own interest. So these are kind of the number of CVT patients that were being screened for my Canadian studies, Secret, and the parallel registry, Top Secret, over the last couple of years of the study. And these are kind of rates when COVID rates were still being reported in Canada. I think this is just like how many were, detected at airports versus, elsewhere and stuff like that. So don't worry about the colors, but it is just kind of interesting how the peaks are somewhat similar. So just for interest. So moving on to presentation, as neurologists, we have the advantage of seeing patients that have an established diagnosis. And unfortunately, this is a very common scenario we see. This is a patient that I cared for previously, typical story, in and out of emerge multiple times with headache. Finally, a repeat scan shows that she's developed a hemorrhage, and then this finally gets everybody's attention. And it's kind of a very suspicious hemorrhage for cerebral venous thrombosis. It's kind of, with a lot of surrounding edema. It's in the temporal lobe, and basically just does not have the look of a primary lobar or a deep hypertensive hemorrhage. And so, we have always kind of anecdotally known that there have been a lot of repeat presentations and misdiagnoses of cerebral venous thrombosis at preliminary encounters, but we're finally getting data that kind of confirms these suspicions with Canadian data. So this is also Lily's work. This is BC-based data in particular, and basically just showing that, there is a large proportion of patients that had, one or more visits in the week leading up to their diagnosis of cerebral venous thrombosis. And unfortunately, you'll see that burden of repeat presentations is borne disproportionately by younger patients and women in particular. And, similarly, we're still working on the analysis from the top secret registry data. But what I can tell you, combining the two cohorts, and this is across 12 centers in Canada, median time to diagnosis from symptom onset was 5 days. But, only about a third of patients were diagnosed on their first encounter with healthcare with those symptoms. So, unfortunately, misdiagnosis is an issue. These are kind of big observational series that show the commonest presenting symptoms associated with CVT. But basically, if I had to break it down, we know there are kind of your increased intracranial pressure type symptoms. Almost 90% of patients in series present with headache, often with associated kind of visual symptoms you would associate with increased intracranial pressure, not just blurred vision from increased pressure transmitted alongside the optic nerves and transient visual obscurations where, your vision briefly goes like gray outs or blue outs or something like that related to very high pressure, but also diplopia. If you recall, the sixth cranial nerve has a very long course through the dura, and so is very sensitive to changes in intracranial pressure. And so some of the blurred vision can actually be double vision as a result of that. And then, pulsatile tinnitus is something that we hear about quite often, but is not really mentioned that often in the series in terms of kind of frequency of symptoms. Then there's the stuff that's related to, focal parenchymal injury and irritation, things like seizures that are very common in about a third, focal deficits, and then kind of the depressed level of consciousness, encephalopathy, confusion type BIN, which, this can be a result of, deep venous involvement of structures like the thalamus, overall mass effect from like a large hemorrhage, or kind of overall increased ICP related to, blockage of the drainage system. So, breaking it down, why does this diagnosis so often get delayed or missed? First of all, we are not thinking of, younger people in general as, typical stroke patients. And, the majority of patients with cerebral venous thrombosis, male or female, overall, mean age is under 55. And the symptoms are not really stroke-like in most cases, unless you have a sudden hemorrhage into your parenchyma or something, that's often an indolent onset, often begins with headache. 20% of the population at any time has migraine. So it's, understandable that this diagnosis might be missed sometimes. And, alongside with that, you don't necessarily have like major heart exam findings, and papilledema can be very hard to detect at the bedside. If you have even if you have an ophthalmoscope that's not broken or something like that, which is so often the case in eMERGE. And then the other thing is that, first line imaging, non-con CT head, does not give you a great view of the venous sinuses. So unless you have, a very astute radiologist who's looking for, hyperdensity and what we would expect for the venous sinuses or deep venous structures, it can be missed. And, something like D-dimer has been examined as a means to kind of be a step in the decision-making process as to whether or not to do a CT venogram to diagnose cerebral venous thrombosis. And, it's just not sensitive enough for those equivocal cases where there are smaller clot burdens or kind of isolated headache. And that's really where you need something distinguishing the most. So, what I would say is, we're trying to figure out how to improve kind of those first line diagnoses. I mean, you would think it has some effect on prognosis to have a later diagnosis. Interestingly, the current literature doesn't really reflect that. But sort of the outcomes at which they're using to measure disability are a bit too blunt for cerebral venous thrombosis. And I'll talk a lot about this in detail in a couple of minutes. I do have a lot of sympathy for people who are frontline. I went into stroke so I could get the diagnosis before I even started. So, I think education is a piece of it. I think, but I think we have to consider how we combine different predictors in order to improve things like just, rules around when we do a head CT. If we do, some brightness that you look in a certain sinus plus a D-dimer cutoff, is that better than just one or the other, for example? Or you look at certain patient-specific risk factors. So I think that's an area that we need to work on with our eMERGE colleagues and family practice colleagues. Again, I think it's, it's goes beyond education, because, when we talk to our colleagues who are frontline physicians, they say, not everybody who walks in the door can get, CT angiogram or a CT venogram, although, literally everybody I see that walks in the door gets one. So, I have a very skewed view. So moving on to updates in acute and primary treatment. What I would say is kind of the biggest, I think, discovery and that, or confirmation of what we suspected in cerebral venous thrombosis over the last couple of years is that, very early recanalization likely matters. How that translates into applications of endovascular therapy is like a real area of controversy, and I'll talk about that. And then the third thing, of course, is the emergence of DOACs for treatment of cerebral venous thrombosis. So I'm just, I'm going to talk about the MRS, or the modified Rankin scale, a few times. And what I would just say is the MRS is a very common outcome scale that we use for acute stroke trials in particular. An MRS of 0 to 2 is a good outcome in that people are functionally independent. MRS of 3, some level of dependence for daily activities and, bedbound and dead. MRS 0 is, 0 symptoms. And MRS 1 is kind of this like very murky category that I think when you think about CVT is difficult. These were recommendations by the Stroke Therapy Academic Industry Roundtable, which is like a big American conference every year where they talk about kind of standards for clinical trials. And they were talking about kind of nomenclature and valences for kind of MRS and in stroke trials in general. But really, like, with cerebral venous thrombosis, for the spectrum of persistent symptoms, I really don't think that you can call an MRS of 1 an excellent outcome. So just to kind of keep that in your mind going forward. So just back to early recanalization. This was a really nice study that a colleague of mine from Portugal did recently as part of her PhD. And basically they had prospective repeat vascular neuroimaging in a cohort of 60 patients with CVT. So they did baseline imaging, they did imaging again at 1 week of anticoagulation, and then again at 90 days. And, this was really novel. They have not looked at very early recanalization in cerebral venous thrombosis previously. And what she found, I think, is very interesting. Number one, that early recanalization is happening really early, much earlier than we thought. At 1 week, more than 70% of patients had at least partial recanalization. And the other thing that was very interesting is that patients that had some degree of recanalization had less new non-hemorrhagic parenchymal lesions and less expansion of existing non-hemorrhagic parenchymal lesions. So, there was less new and worsening damage being incurred in those patients that had at least partial recanalization on anticoagulation, and that was happening really early in the process. What was interesting is that they also found that kind of the day 90 outcomes, however, didn't really reflect any differences in parenchymal damage. So, even if you had early recanalization versus not at the 1 week period, it didn't impact your MRS-based outcomes at 90 days. The study was empowered to look at differences in MRS. And again, I think the MRS is too blunt tool for measuring outcomes in this population. So you would think that, parenchymal damage likely translates to some degree of neurologic disability later on. But anyway, I thought that those were very exciting findings, because I think it opens the door about, like any other type of stroke, should we be aiming for recanalization very early as a therapeutic target? I think we've always previously thought of recanalization in the longer term, like, 3 months, 6 months, 1 year. We've updated a meta-analysis. This is work by Diana Kim, who was one of our residents, who's currently a stroke fellow in Calgary. And basically, we looked at all the literature related to recanalization and outcomes in cerebral venous thrombosis. And, the quality of the literature is heterogeneous. The timing of follow-up scans is heterogeneous. And, a lot of literature is retrospective instead of prospective. So, with all of these caveats in mind, recanalization does seem to be associated with better outcomes overall. Patients who had no recanalization had a higher odds, nearly 4 times rates of kind of worse prognosis, in that it was an MRS of 2 to 6 versus this like quote unquote excellent outcome of 0 to 1. Patients who did not recanalize also had a higher risk of CVT recurrence. And you might be asking yourself, like, okay, how did they define recurrence? Was it really just extension? Hard to know, kind of in the literature as an aggregate. And then another thing that we found was quite interesting was that, lack of recanalization was also associated with chronic headache. And within the meta-analysis, we looked at those studies that, distinguished partial recanalization versus full recanalization. And chronic headache as an outcome was the only case we found where it seemed that partial recanalization was worse than complete recanalization in terms of outcomes. So, with the information that this is an imperfect body of literature, I think it's good just for kind of future hypothesis generation. But I think, another question is, what's the directionality of that relationship, and, how much of this might be born of, specific patient characteristics. In meta-regression, we certainly found that differences in percentages of men in any given study certainly affected the study results. We couldn't really find that by age, but that's just because the mean age between different studies was like very similar overall, because it's a CVT population. The other question I think we're always asking ourselves is like, how long should we be, anticoagulating for? Are we using recanalization as a marker? How long should we be going for this for? This is a study from my colleagues who did the ACTION CVT study. So this is a recent observational study, kind of routinely collected clinical data, but it's international, and they had a lot of patients, over 1,000. And basically what they found was that like most patients had near complete recanalization at 3 months, and there were really diminishing returns on follow-up scans, with the knowledge again that this is imperfect clinical data, and there are a number of patients who aren't returning for follow-up scans after that. But it just kind of begs the question, okay, if this patient really hasn't recanalized by like 3 months or 6 months, should we really, be aiming for this as a therapeutic target? Is there any potential benefit? And should we just really be thinking about secondary prevention, antithrombotic strategies at that point? So of course, the other thing that we're all asking, especially in stroke, is, what about the role of endovascular therapy in cerebral venous thrombosis? I think in general, it's being seen as a rescue therapy where kind of first-line anticoagulation has failed and that the patient is deteriorating, or there's like a worsening hemorrhage, which is a rare but serious situation, or the patient can't be anticoagulated for like whatever very, very rare reason. I would say that, I'm aware of some centers, primarily in the States, where they are doing a lot of EVT very routinely. But in general, I think that the trend internationally is to be using it in the cases of clinical deterioration. And I'll talk more about these trends in a minute. But what I would say in terms of considerations around endovascular therapy for CVT, number one, the risk-benefit calculus is different than it is in arterial stroke. The risks can be higher. We don't have dedicated tools for venous sinuses, and the prognosis is different. We aren't having a lot of functional dependence in most cases with patients with cerebral venous thrombosis. So, it makes you ask, okay, what's the threshold for the sort of patient that is a good candidate? As I mentioned, there are not dedicated tools for the venous sinuses. And, in turn, there's a lot of variability in how people actually get clot out of the sinus. Some use a balloon and try to pull out clot, and there's a theoretical risk of, PE with that. Some people put in a little catheter, a microcatheter, and they infuse in thrombolytics for a period of time. So there are a lot of different techniques, and these are tools that are not indicated, they're not intended for the dural sinuses. This is a review from a colleague of mine, basically just showing kind of what an ideal catheter size would be for a venous sinus versus the sort of catheters that we have for arterial intervention that are available. And then the last thing is that there was one clinical trial that didn't show an advantage. This is the 2-act trial, which was published a couple of years ago by my colleagues in the Netherlands. It was an open label randomized trial. Their threshold for inclusion was basically having some sort of, unfavorable prognostic characteristic that was identified in previous observational series, depressed level of consciousness or encephalopathy, involvement of the deep venous system, or any sort of blood in the head. And, as you can imagine, there's a huge spectrum to that. Patients were randomized to medical therapy versus whatever type of endovascular therapy they were using at their institution. And the outcomes were modified Rankin scale of 0 to 1 versus 2 to 6 at 12 months. The trial was stopped early for futility. Recruitment was also slow because these more seriously affected CVT patients are rarer. So overall, there were only just, less than 70 patients that were randomized in the trial. In the endovascular group, 10% had a complication related to sinus perforation with the endovascular treatment. So, again, not dedicated tools for use in the sinuses. And this is MRS of 0 to 1. And if you're tempted to interpret anything of the shift, again, I remind you that there are only 33 and 34 patients in each group. So, in this small trial, they did not show any effect. But, again, there were a lot of things I think the investigators would change with the benefit of hindsight about who they were including and what they would do in terms of techniques. So a colleague of mine in the States and I are with one of our neurosurgery residents, Alex Rebchuk, who's been doing research with me for a long time. We have an international survey going on right now. We have about 900 respondents, and this is just kind of some preliminary data. So, one thing I have found very, very interesting as a pattern, when we ask people to talk about very important factors to consider prior to endovascular therapy, there's a huge focus on kind of the patient's clinical picture, but there's not that much of a focus on their neuroradiological picture, which is interesting because having an accessible clot and having certain neuroimaging features are very much how we kind of do our decision making around endovascular therapy. We take the clinical and the radiological factors together. So kind of this mismatch is quite interesting to me, and as to what people are overall considering to be important versus not important. And if you look at administrative data, things like the national inpatient sample in the States and things like that, it really does look like they're just reserving this therapy kind of as a Hail Mary type treatment in patients that are already doing poorly. So I really think we need to work harder on selecting patients that, have room for benefit before they deteriorate. And I think that's a big question that many of us are working on together internationally and planning future trials. I'll just give you an example of a patient that I had who had deep venous involvement. And, she was elderly, had a stroke-like presentation when she came with left, you can see her left thalamus is hypodense compared to the other side. And you can also see, even though this is a non-con CT, the relevant hyperdensity in the deep venous system here. She was put on low molecular weight heparin right away. She was diagnosed at her first presentation. And despite that, she was deteriorating, was nearly comatose in less than 24 hours. So this was a sort of patient that, we thought, okay, well, she's not doing well on anticoagulation. This is the sort of patient that might be a good candidate for endovascular therapy. Raju Heron, who many of you know, did the procedure. Hopefully this will show up for you. Yeah, so basically, what you will hopefully be able to see is that the venous system was quite blocked pre-procedure, and you can see just how nice and open he was able to get the veins. It's the sort of effect you always hope for endovascular therapy. She woke up immediately. She's done really well. She was discharged quickly and functionally independent. This is another case that was treated conservatively that just kind of, at least neuroradiologically and at the beginning of the clinical picture, just kind of reminds me of the first patient, and that, they presented fairly acutely, younger and independent, with thalamic involvement. Actually, the thalami were so swollen that it actually obscured the third ventricle, and they needed to put in an EVD, a drain, in order to deal with the hydrocephalus. But with all of that, the patient ended up being treated medically alone, and neuroradiologically the picture had resolved after about 10 days. But this patient was actually, despite having a very nice looking scan, was quite disabled and had a long period of time in inpatient rehabilitation. So I just find it's an interesting contrast. I could never, of course, with N of 2 say for sure whether endovascular therapy would be a deciding feature here, but it's just kind of interesting, and it does get you thinking about who might be a good candidate. So just talking a little bit more about primary anticoagulation, of course, we are facilitating recanalization, of course. We're also treating the hypercoagulable state, and we're preventing further clot extension. The previous literature is proliferating, looking at use of DOACs for CVT instead of, warfarin as an oral anticoagulant, which was previously, the only first line available. I'll talk about my study SECRET in a minute. There were 2 randomized trials besides SECRET. There's the RESPECT CVT trial that was published a couple of years ago looking at dabigatran. There was Einstein Jr., so pediatric venous thromboembolism trial, but there was a very large subset of children with CVT in particular. And then the other big study that was published before our trial finished was ACTION CVT. So again, this was the very large retrospective observational study. But it was done, in this contemporary period where people might have been using DOACs as part of their routine clinical care. So there was the opportunity to make indirect comparisons there. Basically the punchline. So RESPECT CVT was a randomized trial, 120 people overall, 60 with dabigatran, 60 with warfarin, and they had 5 to 15 days of lead-in parenteral anticoagulation prior to initiating DOAC. They didn't have any recurrent venous thromboembolism at 6 months. There was 1 GI hemorrhage with dabigatran and 2 symptomatic intracranial hemorrhages with warfarin, and really no differences between groups with respect to rates of recanalization, and no differences in functional outcomes. With the pediatric trial, Einstein Jr., the outcomes were at 3 months, and they randomized 2-to-1 for rivaroxaban versus standard of care, which could have been ongoing low molecular weight heparin or use of warfarin. And, what was interesting about Einstein Jr. that, has been an exclusion criteria for some of these other studies is that, a large proportion of these pediatric CVT cases were in the context of infection. So basically there was 1 subdural hematoma in the standard of care group, no clinically relevant non-major bleeding in that group, but with rivaroxaban, no major bleeding, but they did have 5 clinically relevant non-major bleeding events. But again, no real differences in rates of recanalization at 3 months. And ACTION CVT, so much larger cohort, but again, retrospective observational data. They found no differences between groups with respect to venous thromboembolism recurrence, but there was a reduction in major hemorrhage in favor of the DOAC group that was born primarily, not surprisingly, out of a reduction in rates of intracranial hemorrhage overall. And again, no differences in recanalization between groups. My trial, which was a Canadian trial, was more focused on kind of feasibility for future trials of antithrombotics in cerebral venous thrombosis. So, our primary feasibility outcome was just rate of recruitment. We had primary safety outcome as a composite of symptomatic ICH, major extracranial bleeding, and death at day 180, and secondary outcomes being, efficacy markers like VTE recurrence rates and recanalization, and also functional and patient-reported outcomes. Patients were randomized 1-to-1 to rivaroxaban versus standard of care, which we took as either continuing low molecular weight heparin or warfarin. And we were only looking to recruit 50 patients in this feasibility trial, but we also had a parallel registry. Both, we know from other trials that not everybody is going to consent to randomization. And we also wanted the opportunity to follow natural history in those patients as well. So, what I would say, again, the big distinguishing features of, our feasibility trial versus what was before, we have detailed information about feasibility of recruitment with the parallel registry. We actually, unlike Respect CVT or Einstein Jr., had no requirement for any lead-in parenteral therapy, so patients could just be, diagnosed and randomized. And our initial dose of rivaroxaban was the 20 milligram daily dose. We didn't do the BID, and this was due to Bayer's preference for what they perceived as a lower rate of intracranial hemorrhage. We had the detailed prospective outcomes, and primary outcome was at 6 months, like the other trials, but we did follow our patients up to 365 days. So what I'll tell you about the secret population is that it's different than what was in the registry. We know that women are less likely than men to consent to being randomized into antithrombotic trials, and we saw that pattern here as well. Only about 2/3 of patients in secret are female. 3/4 of our patients in the registry are female, and patients are a little older than kind of the mean age in other observational series. Overall, you can see that patients are pretty mild at presentation with a low NIH stroke score, and about 30% had some degree of intracranial hemorrhage at baseline. So a lot of patients received DOAC before that 5-day window that other trials were using. So, 42% of patients were randomized within 2 days of their diagnosis and 62% within 4 days of their diagnosis. So, it's a small trial. It's a small rivaroxaban group, but a lot of those patients got their rivaroxaban early. And what we found in terms of primary outcome was that, it was interesting. There were no bleeds in the standard of care group at all. We had one symptomatic intracranial hemorrhage in the rivaroxaban group. This is someone who, at month 4, had a spontaneous subdural hematoma. So, not a clear explanation for why that happened, and ended up going off anticoagulation early. We also had 2 clinically relevant non-major bleeding events in the rivaroxaban group, both of which were related to gynecological bleeding. It was interesting, we had just standard of care INR monitoring. Sites were just expected to, submit blood work alongside kind of their routine follow-up visits. 71% of visits reported INRs. Interestingly, 84% of those in the reported visits were therapeutic. So, it seems at least that INRs were therapeutic. Certainly, we aren't seeing event rates that suggest that they weren't. We had one recurrent venous thromboembolism in the rivaroxaban group at 6 months. This was someone who was not taking their medication as directed. And one person in the rivaroxaban, in the warfarin group who was subtherapeutic, had CVT extension but didn't meet the criteria for recurrence. The other thing that's interesting is that every single patient who had follow-up imaging had some degree of recanalization at by 6 months. So, which is different than what's reported in some of the other trials in terms of rates. When you follow up patients to day 365, and we had very good follow-up for most patients, very few dropped out. Most patients stayed on anticoagulation for close to a year. And we ended up with one symptomatic intracranial hemorrhage in one patient in the warfarin group who also, it was a traumatic event, and they had, a scalp laceration as well. So that was a major bleeding event in that group as well. And patient later ended up dying for unrelated reasons, but, overall low event rates and not particularly different than the rates we were seeing in the other trials looking at DOACs for CVT. So, and the other thing just to point out is that, diminishing returns with respect to any additional recanalization that was happening in the patients that got imaging between 6 months and 12 months. So, What I would say is that, in this lower risk patient population, we haven't identified any major safety concerns about unacceptable risks of bleeding in DOACs as compared to vitamin K antagonists. What I will say is that, running a clinical trial is very, it's an interesting experience. You get the sense that, maybe not all clinically relevant non-major bleeding, and in particular, heavy menstrual bleeding, is not being well reported in these trials. And, looking at the way that clinically relevant non-major bleeding is reported, it doesn't necessarily cover heavy menstrual bleeding, which of course is a very relevant outcome to a population that has a high representation of younger female patients. So I think this is something that we're really going to need to do better at measuring in future trials. But the other thing is, I don't think there's anything magical about having, 5 to 15 days of lead-in parenteral anticoagulation if the patient is otherwise a suitable candidate for oral anticoagulation. I'm currently working with the Action CVT group on a sub-analysis of their data related to timing of DOACs in their patient population. I can't share too much information, but what I'll tell you is that the vast majority of patients were also getting their DOACs, before that 5-day period. So, again, for next steps in terms of trial design, I think it is going to be really hard to convince most people to do a randomization study between vitamin K antagonists and DOAC, given kind of the way that patterns of practice have evolved, and especially the way that patterns of regular INRs have shifted. Obviously in patients who have antiphospholipid antibody syndrome, this is not the sort of patient I would want to put on a DOAC. And of course, patients that are pregnant and breastfeeding, it's also not kind of a desired population. But those are, the minority overall in terms of who's being represented in this lower risk population. I think in terms of, what we look at in terms of a composite outcome is going to be flexible in terms of accounting for these patient-centered outcomes. And again, I think we need to fold some way of measuring heavy menstrual bleeding into that. I think it's something that, certainly we have not been recognizing enough as an important outcome in these trials. And certainly I would say that the thrombosis community is way more evolved than the neurology community in that. And, I've learned a lot from the existing literature from the thrombosis community. And I think we really have a lot to, gain from further collaboration in that regard. So just moving last on to updates in prognosis. We had a patient forum prior to doing the CVT trial to get some feedback about kind of important patient-centered outcomes to include in this trial and in future ones. And we had a graphic recorder, which was really nice. And kind of this central panel, I think, really sums up the nature of the conversations that we were having. Physician is telling the patient that they're doing really well, and the patient is trying to explain that, there are some unmeasured issues related to quality of life that aren't fully being appreciated, just because they can walk and talk. So, thinking about prognostic information that matters, we have kind of the clinical stuff. What's the rate of death? What's the rate of VT recurrence? Rates of vision loss, seizures, stuff like that. And of course, patient-centered outcomes, things that count, in any post-stroke population: headache, mood, fatigue, cognitive impairment, and overall quality of life and other things like that. So in secret, and again, I'll remind you of the modified Rankin scale: 0, no symptoms; 1, some symptoms, but functionally independent, up to an MRS of 2, and then greater disability after that. What we see in the secret population overall is that, even at baseline, most patients are starting off with functional independence, and it only really gets better from there with respect to their MRS scores. And it's a very busy slide, but basically what I'm showing you here is that when we looked at patient-reported outcomes related to overall quality of life, depression, burden of headache, fatigue, and cognition, patients were impaired at baseline on average. And interestingly, over 60% of patients, with a mean age of less than 50 in the cohort, had abnormal cognitive performances on their MoCAs at baseline. Overall, as a group, there were marked and continued improvements up to 6 months and moving up to a year, and no differences between the standard of care and rivaroxaban group, but high rates of attrition, in particular with regards to cognitive follow-up. So, even though there was improvement, a lot of patients just were not interested in doing those tests over and over again, despite being happy to do the other patient-reported outcomes. So yeah, basically what I would say is we need a measure of cognition that is more tolerable to this traumatized population. Patients overall improve over time, which is good, but we have to ask about their outcomes and not just take functional independence as being good enough. So the other thing is just with respect to clinical prognosis in general, every group is now developing their PET risk score. And what I would say on average is that, age and depressed level of consciousness and having some degree of hemorrhage and malignancy are kind of common features with regards to poor prognosis between groups. What I think is an important distinction to make is that, your prognosis at presentation really depends on age and your characteristics at presentation. So people that, have a lot of seizures, have bad scans, have depressed level of consciousness, that really impacts their shorter term outcomes. But when we're thinking of longer term outcomes in terms of mortality at, 3 months, 1 year, things like that, it's more age and malignancy that seems to make the difference. This is unpublished data currently under consideration. Again, another analysis done by Lily Jo with BC based data. And basically what we found is that, mortality rates at 1 year for cerebral venous thrombosis were actually pretty high. When we talk about mortality in CVT, we think of kind of like short-term mortality, about 10% of patients, 5 to 10% of patients, die during that initial presentation, but we, consider less about what's happening over the longer term. And you can see overwhelmingly that this is associated both with age. These are youngest patients at the bottom and oldest patients at the top, and risks of mortality over time, and also overwhelmingly associated with malignancy. Just a couple of last things. One with respect to rates of VTE recurrence. Basically, again, heterogeneous data quality, differently durations of follow-up. Overall, on average, what's been reported is, in all comers, about a rate of recurrence of 4 to 7% per year, and about half of that borne by the risk of CVT in particular. Recently, the Action CVT group did a sub-analysis of their data, and they also found kind of similar rates. The median follow-up was only, it was a little under a year, but again, similarly, they found about a 5% recurrent rate of VTE overall, and higher risk of CVT than is reported in the previous literature in terms of making up that proportion of recurrence. And they had a big proportion of patients from the US where they found that being Black was a predictor for recurrence, in addition to having a history of venous thromboembolism and some sort of positive antiphospholipid antibodies at some point measured during the patient course. And really no difference with regards to sensitivity analyses with patients that had events occurring versus on versus off oral anticoagulation. And, they made the point, as with, the rest of the VTE literature, that kind of this risk is likely not, any sort of, genetic thing. It's more likely due to social determinants of health in terms of recurrence. They found that patients who were Black had less INR readings overall. And, just again, something to keep in mind in terms of quality of care. And one last thing to measure, to mention is just, when we think about long-term burden of CVT, we think about functional independence, but we don't necessarily include seizures as a factor that we're thinking about in there. And I just wanted to kind of remind people that the long-term risk of seizures is actually pretty high. It's about 10% overall. Patients who are at risk for seizures, tend to have some sort of parenchymal injury at baseline. People who have seizures very early on in their presentation, especially status epilepticus, have a higher risk of long-term seizures. And of course, just with like any other type of patient with stroke, decompressive hemicraniectomy is also a risk factor for developing seizures. Other things that we think of in terms of medical complications of CVT, one thing just to kind of be aware of is risks of dural AV fistula. There was one study from the Respect CVT group, and basically at 6 months with kind of dedicated follow-up imaging protocols, no one had a recurrent, no one had a dural AV fistula. But in some other observational series, they report that the rates are about 2% overall. I would say based on our experience, it's probably higher than that. It's probably about, 5% of patients that are presenting with dural AV fistula later on. The way I have tended to find the patients with dural AV fistula is that, there'll be a CVT patient who is doing fine, and then they'll come back to me and say like, hey, I have this new headache, and you'll scan them and you'll bring them back. And like, just as they're leaving and they're like, oh yeah, and the headache goes whoosh, whoosh, whoosh. And you're going, okay, have a much higher index of suspicion for dural AV fistula. The other thing I would tell you about looking for dural AV fistula is don't trust the radiology report. Sometimes these findings are really subtle, and you'll kind of be looking going, I think even though it's reported as normal, the veins are really asymmetric. And when I go down and review with specialist neuroradiologists at VGH, we've definitely found dural AV fistulas that were confirmed on angiography, that on scans that were previously reported as normal. So I would say if you have a high index of suspicion, don't be satisfied with the report alone. The other thing that I think is something that we don't pay enough attention to for CVT is the risks to patients' vision. Long-term increased intracranial pressure with papilledema can give patients enlarged blind spots and concentric vision loss. And these patients are young, and, who knows about the increased risk of vision loss, when you add things like glaucoma over it long-term. And, certainly this is something that is preventable if it's caught. We are not great at bedside exam in terms of detecting papilledema. And certainly, patients may have papilledema without noticing any sort of visual symptoms on their own. So I routinely refer all patients for an ophthalmology assessment that have a new diagnosis of cerebral venous thrombosis. And the other thing that's kind of interesting is that despite full recanalization, some patients actually develop this IIH type picture. So there's, like idiopathic intracranial hypertension, patients recanalized, and yet they somehow develop papilledema later. And whether this is due to like issues with, arachnoid granulation drainage, or whether some of these patients have an occult transverse sinus stenosis or something like that, like reasons aren't entirely clear. Rates are not entirely clear. I can think of 3 patients in the secret and top secret cohort that had reported late papilledema. So I get kind of the preliminary follow-up, and then I make them do another follow-up at the 3 to 6 month point. I don't have great data to support that yet, but hopefully that'll come in time. So there we are. I would, sum up that it's a really exciting time for research in CVT. There are a lot of very active groups, and hopefully we can continue to work together to find more about this rare disease, and especially in collaboration with our thrombosis colleagues. We know that it's more common than previously reported and more common in men. We need to find better ways, I think, to prevent delayed diagnosis, especially in younger women. There is definitely a role for considering, benefits of early recanalization, but, how we kind of translate that to judicious use of EVT remains to be seen. DOACs are now used widely, and they're okay in lower risk patients. We know that the burden of disability is higher than what is previously reported, and we need to ask. And again, just refer these patients to ophthalmology. So thank you for your attention. Happy to discuss.